All right, while our devotional is getting set up, Barbara asked me to hand this out to you. This is your Victorville forms that you need to complete. She wants them back in her office by this Friday at 1 o'clock. So complete these forms, and then they'll be able to do the checklist of your background check and everything. They check everything. You cannot go in that facility without getting a background check and the whole bit, because it's a federal prison. So I will...
Date, a specific date, or should we leave the date blank?
Follow the instructions. She's got instructions on the top of these. She just asked me to hand them out to you.
Here you go, sir.
All right, everybody stand up for a minute.
Jumping jack again?
So, one of the research projects that I did with students for a couple of years was range of motion. And I'm going to stand this way, like I'm facing you. But dental hygienists have a great range of motion going this way. But most of us can't go much more than that. I'm stuck right here. That's as far as I can turn my head to the left. Okay, so that's bad. Can you see what the big difference is? I can go this way, but that's about as far as I can go this way. So, and that's 40 years of practicing. So I want you to be sure that you continue to stretch the opposite direction as well. I also have a trainer that works with me because we work like this, and she's constantly asking me to open up the rib cage. And so be sure that you're doing that. Ways to do it is in a door jamb or stretching out, but really try to put your arms across here, turn them backwards like this, and push. So you continue. Did that stretch feel good? Most of you had clinic this morning. Feels really good. So just stretch it out, stretch it out. How far can you stretch your hands to touch?
I'm not very flexible.
She can touch it.
Okay. Reach up, reach up, reach up. Push, push, push. Okay, now reach to your right. Now reach to your left. Doesn't that stretch feel good? And reach up. Okay, now this one, I don't know if you could do it, but this is something that my trainer has taught me. She said, when you try to reach down to touch, wait. Just hang. Don't try to reach. Just reach your body down and just hang there. Just hang, and you will slowly go down further and further as you keep hanging. Doesn't it stretch? Feels good. All right. Have a seat. That feels good, doesn't it?
Yeah.
Sorry.
So this afternoon, I asked Kayla to do a devotional for us. I think you guys are tired of my devotional, so I'm going to get some of you guys up here. I'm looking for someone for next week, so if someone would like to volunteer, I'd like to do that. So if you guys would give Kayla your full attention, I'd appreciate it.
I am going to ask that everyone closes their laptops, just like Miss Lee does, so I have your attention. Okay. This is a devotional I put together for today. I titled it, I Have Seen the Hand of God in My Life Today. And I'm going to start with how we see the hand of God in our lives with Matthew 5:14-16. Which reads, "You are the light of the world. A town built on a hill cannot be hidden. Neither do people light a lamp and put it under a bowl. Instead, they put it on a a stand, and it gives light to everyone in the house. In the same way, let your light shine before others, that they may see your good deeds and glorify your Father in heaven. This is a poem called The Shoe Man by Leanne Freeberg. It goes, my alarm went off. It was Sunday again. I was sleepy and tired, my one day to sleep in. But the guilt I would feel the rest of the day would have been too much, so I'd go out and pray. I showered and shaved. I adjusted my tie. I got there and sat in a pew just in time. Bowing my head in prayer as I closed my eyes, I saw the shoe of a man next to me, touching my own. I sighed. With plenty of room on either side, I thought, why must our souls touch? It bothered me, his shoe touching mine, but it didn't bother him much. Our prayer began. Our Father, I thought, this man with the shoes has no pride. They're dusty, worn, and scratched. Even worse, there are holes on the side. Thank you for your blessings, the prayer went on. The shoeman said a quiet amen. I tried to focus on the prayer, but my thoughts were on his shoes again. Aren't we supposed to look our best when walking through that door? Well, this certainly isn't it, I thought, glancing toward the floor. Then the prayer was ended, and the songs of praise began. The shoeman was certainly loud, singing proud as he sang. Sounding proud as he sang. His voice lifted the rafters. His hands were raised high. The Lord could surely hear the shoeman's voice from the sky. It was time for the offering, and what I threw in was steep. I watched as the shoeman reached into his pockets so deep. I saw what was pulled out, what the shoeman put in. I heard a soft clink, as when silver hits tin. The sermon really bored me to tears, and that's no lie. It was the same for the shoeman, for tears fell from his eyes. At the end of the service, as is custom here, we must greet new visitors and show them all good cheer. But I felt moved somehow and wanted to meet the shoeman, so after the closing prayer, I reached over and shook his hand. He was old and his skin was dark and his hair was truly a mess. But I thanked him for coming, for being our guest. He said, my name's Charlie. I'm glad to meet you, my friend. There were tears in his eyes, but he had a large, wide grin. Let me explain, he said, wiping tears from his eyes. I've been coming here for months, and you're the first to say hi. I know that my appearance is not like all the rest, but I really do try to always look my best. I always clean and polish my shoes before my very long walk, but by the time I get here, they're dirty and dusty like chalk. My heart filled with pain, and I swallowed to hide my tears as he continued to apologize for daring to sit so near. He said, when I get here, I know I must look a sight, but I thought if I could touch you, then maybe our souls might unite. I was silent for a moment, knowing whatever was said would pale in comparison. I spoke from my heart, not my head. Oh, you've touched me, I said, and taught me, in part, that the best of any man is what is found in his heart. The rest, I thought, this shoeman will never know. Like just how thankful I really am that his dirty shoe touched my soul. This story really spoke to me because I think about us as clinicians and going into clinic and having a patient that we've never met before, and just seeing them and looking at their health histories. We only get to know them to a certain point, but we don't really get to know what these people deal with on a day-to-day basis. And we have time, valuable time, to talk to them for 4 hours, which is a big chunk of my day and their day. So you just really never know a person's story. This related and spoke to me in my life, just coming back from a missions trip. And on this missions trip, we would have our clinic days and we'd be busy running around. And at the end of each day, we'd come into the cafeteria and we'd gather together and eat dinner with one another. And for hygiene, it was mostly dental students, so we didn't know anybody at all. And so we were trying to make connections with everybody. And we would always sit at the same table, and I saw this older gentleman who was one of the doctors that came onto the trip with us, and he would always, slowly mosey around and, just sit at a table. And the first 2 days we were there, I noticed that he would kind of just like sit alone, and he'd be lucky if someone sat next to him and started talking to him, but it was always kind of like a awkward, like, I'll sit next to him because he doesn't have anyone sitting next to him type of thing. And one night he came and asked me and Sunshine if he could sit at our table, and we nurtured a conversation to get to know him, and it went on to be him just like telling us about his whole life and everything he's done in his life, all the amazing adventures he's been on, his family, things that he's excited to do once he gets back home, to retire. And then, we went to sleep ready to enjoy our first free day of the trip. And so we woke up and we had this free day where we saw God's beauty in creation in a way that I've never seen before, and it touched my soul that I'll always remember. And that same day, we came back from the free time, and we realized that that man that had sat next to us died that day. On the free day, he went out and he didn't come back. And it was very shocking to me to experience somebody and to give them time and get to know somebody, not knowing that I wouldn't see him ever again. So that really touched me. And God calls us to love each other. In John 13:34-35, he states, "A new command I give to you. Love one another as I have loved you, so you must love one another. By this, everyone will know you are my disciples if you love one another." And as I was reading that, I just think it's so interesting that we have to be commanded to love one another, because it's not something that we naturally just want to do. And I hope with these sermons and that poem, you guys look to your left and you look to your right and you think about your family and your friends. And if that person to your left or right was gone suddenly, would you be okay with how you had a relationship with them? Would you be okay knowing about what you said behind their back or to their face or whispered to a friend? So just think about that, because tomorrow is never promised to any of us, and life is so short. Life is more important than those little things, and we should really focus on the shortness of that time to love one another and shine our light from within for the glory of God, to do his handiwork. So that's how I want you to take this devotional today, to just take time with our busy coursework to just take a minute and realize how you see God's hands in your life. Because if you do that and you take that time for yourself, you fill yourself up with joy, and you're giving yourself that refresher, and you're filling yourself up so that you can pour that love out into others. And be that hand of God that somebody else gets to see today. That patient that sits down in our chair, we have 4 hours with them, and you never know if you're the first person that could show them a loving hand. You never know if they're getting that at home or what the situation may be. So our 4 hours up in clinic is just not for competencies and getting through the appointment and just rushing through and try not to make any mistakes. It's more than that. So I hope you guys can take that into today, and I'm going to pray for us to start off our class time. Dear Heavenly Father, I thank you for this opportunity to read and focus on your word. Thank you for allowing me the time to share in my devotional with my classmates and to wrap up the last part of our day. I pray that we all remember the story of the shoe man, and we just take it with us in every step of our day from here on out. I pray that we can love each other and take time to connect with one another and strangers so that we can be a light to other people's life for your glory. Lord, don't let us think that tomorrow is promised. Let us live in love and intention, knowing that what's important and what's not with so little time that we have here. Lord, let us be the hands of God that someone sees in their life today and in each day for as long as we all live, so that other people that may not get the opportunity get to feel your love through us just as you love us. I pray all these things in your name. Amen.
Thank you.
Thank you.
So while I get my computer connected here, I got a note from one of the faculty today saying that more than one person in her pod had problems putting a note into axium. So I'm going to give you a scenario. Last week you saw a patient, you did a data collection, you made a treatment plan, you called it a perio maintenance. You wrote a note, right? Now you have the patient come back the next week and you finish their perio maintenance. Where do you put a note? How do you put in a new note?
You right-click perio maintenance
You right-click perio maintenance.
and add treatment now.
Okay, so a couple of people were clicking on the old note and then leaving a space and then adding a second note to that. You cannot do that because once that note is written for that week, you can't add to that note. What you have to do is highlight the perio maintenance and then right-click, add a treatment note, general note, and then you add a second one. There will be an arrow that comes down off of the maintenance the first time for the first note, and then you'll have another arrow that comes down for the second note. And if you see them 4 or 5 times, there will still be arrows coming off of that treatment plan. Okay, so I have a perio maintenance in my computer, right here. I'm going to highlight it, right-click. When I right-click, it says add treatment note. When you add treatment note, you say general note, then you can add another note. Once you wrote that note for today, don't change that note next week unless something is wrong with it. You just have to add another note. Right-click on that treatment note, add a general note. Is that clear? Yes.
So when your perio maintenance is incomplete and then come back to get the completion, you go back to that same.
Go back to, you're still working off of a same perio maintenance treatment plan. We haven't changed it. The only thing that would be different is if you're doing scaling and route planning and you have 4 quadrants of route planning and you have a perio re-eval, you are going to highlight the one that you did. Like let's say you did upper right last week, you'll have a note attached to the upper right. Let's say you're going to do the upper left today, then you're going to highlight the upper left quadrant, right click, add a treatment note, general note, and it will come off of that. Okay, now the other 2 quadrants, same thing, highlight those, get those in there. Re-eval, you're going to do the same thing. So the note for the re-eval is attached to the re-eval. The note for the upper right and upper left and upper lower left and lower right are all coming off of those treatment plans. Okay, is that clear? There's still, faculty were saying that number in her pod were doing it incorrectly, so I want to make sure that's clear. All right? Is there any other axiom issue that you're having problems with?
This one, I'm not sure how to ask the question, but sometimes I feel like certain, let's say I write a note, and to say it's not specific enough. And then so some instructors have I'd say more specific way of writing it.
Agree?
So I've tended to like take a picture of the treatment note before so I can kind of copy it to kind of give me an idea how to write a treatment note correctly.
Okay.
But how am I writing everything that I see, I've experienced, or just the treatment part of it?
Okay, good question.
And another question on the same kind of coming off of hers, like is it supposed to be full sentence with grammar?
What you're talking about, I know exactly what you're talking
Okay,
about.
because that's a little, that's like a discrepancy that is,
I know that.
takes a long time.
I know exactly, and I know exactly who. We have the same problem. Okay, let me explain it. I'm all about thorough, but concise. Okay, does that make sense? I don't have time to read a book, but you need to be thorough enough that you have enough coverage if you took it to court. But you need to be concise enough where you don't have to write everything totally out. Okay, so for example, if I was writing a treatment note, I would write, just like I've written on sample treatment notes, HHX, health history reviewed, comma, vitals, comma, EOIO, within WNL, comma, data collection, comma, treatment plan, colon, perio maintenance, patient category 1, AAP 1 or 2, ASA 1 or 2, comma, plaque score, 100%, OHI, and then whatever you gave, whatever you talked about, whatever that perio stuff you talked about, come back around. Then you're going to do ultrasonic and hand scaled, full mouth, moderate generalized bleeding, and I do mod gen, and you could do hemo or bleeding. Then you can say polished and floss, full mouth, patient complete, 6-month recall. Now, if we talked about or we found other lesions, like in the EOIO, you can talk about those, write them there. We can talk about some incidents that may have happened with the gingiva or with the bleeding, or patient was able to tolerate ultrasonic, or use ultrasonic at lower level, or whatever you need to do to add in the extra that's going to help cover. Now, if you had an incident that happened with the patient, like a misunderstanding, or a patient was upset, thought she was coming in for a cavity filling and was scheduled in hygiene, you have to describe all of that so you cover yourself. Does that make sense? Is that enough information, do you think, cover legally for everything you did, and yet concise enough? Yes.
So for like if we say it's like a fibroma, or say if it's like a linea alba or anything, that's not, is that too general?
You can add that in, or you if you have stuff that has like a lesion. Let's say you had a fibroma, 1 centimeter fibroma on the left commissure lip. Okay, so if it's right here, put that in, draw it in under the EOIO section,
Okay.
and draw that in.
So I reviewed my health history of my patient. There was a lot of things that weren't in there as far as like he had a cancer removed on his shoulders and his head, and it was nothing like that was written in there. So I updated it.
Perfect.
Does that need to be in the treatment?
Nope.
No, that's within
Nope.
the update.
Yep. That's supposed to tell you what you do, and then you can go to the other sections to really figure out what that all is. Because then your gingival assessment, you know, we're in perio page 5. Perio page 5 is going to have all the information about, okay, there was plaque here, this lesions here, plaque here, you're using this You found the gingival color, contour, consistency. That's all in your period page 5, right? So you don't really have to put all of that in the note, but maybe you're going to write something general, because if I'm a hygiene student and you, I'm seeing the patient, Sunshine saw the patient first, I would like to know a little bit.
Can you put C, perio page 5?
Yeah, absolutely, you can do that, but they should see it. It's there. You don't really need to do that because we know it's there, but you might want to say severe gagger. I want to know that right in that note right there. I don't want to have to go hunt that down. That's something that's going to affect my treatment. Okay, so anything's going to affect my treatment and I'm reading it the next time. Also, if you're doing OHI, Sunshine saw the patient, didn't finish, patient's coming back. I'm going to do the patient now. I want to know what she talked about. If you did OHI, did you talk about perio, did you talk about caries, etc.? I want to know. Okay, so give me enough information, but I don't want you to write a whole book. It's not necessary because I can go to perio page 5 and read color, contour, consistency, gingival, marginal, papilla, all of that. You don't have to write all that in that note. Okay, AJ, you had your hand up.
You covered it.
Okay. All right, Sarah.
Any chance we have another Victorville, actually two?
Is there an extra Victorville paper?
Two, yeah.
Go back up.
Good looking, Sarah.
Okay, well, it's starting to feel like Death Valley here, right? It's getting warmer and warmer.
Yep.
Okay. But really, if you think of Death Valley, how ugly it is, actually Death Valley is really pretty, depending on when you go and what time and what's going on. I took this, I didn't doctor this picture. This is what I took. It's a painter's canvas of it. It's a really pretty place. Anyways, okay, picture yourself watching a movie. How many of you have watched a movie and then watched that same movie again? How much more do you pick up the second time? Way more, like you totally got the story now and now you're picking up all the details. That's kind of what I'm going to do today, so bear with me because I'm going to kind of review a little bit on case presentation and treatment planning. As I told you before, that's the number one thing that people are having problems with, filling out that form, what the information is, where do I get that information, what am I doing? So that's what I'm going to do. AJ?
Okay, I have a question about that. If we believe that we have the treatment preset, do you want us to put it in the code before you come?
I have asked you to do that.
Yeah.
Is that clear? I made an announcement, I think on announcement on Canvas. If you come up with a treatment plan, I want it entered in there. We can always delete it, but we want you to start having that already in there. So if I came to someone today, is your treatment plan entered? No, but I asked you to enter your treatment plan before we got there. Okay, so it's saving us time to get through that. Okay, so our dental hygiene process of care case presentation. Just a quick review. It's data collection to come up with a treatment planning, then to do the treatment. So what is treatment planning? What we're doing is gathering information. We want to know what the patient wants. Okay, if the patient is in here and they really want to get their teeth whitened, but they got a ton of plaque and calculus on there, we still need to know what they want, but what they want and what they need may be different. We're going to organize all of our thought processes. When you look in someone's mouth, there's all kinds of things that you see, but how do we organize it? That's what we do in our data collection. We get it all together, and then we come up with a plan of action. What are we going to do for this patient? And why? We have to have information from that data that will talk to us, that will tell us what we need to do. We're going to evaluate that data. And then we're going to formulate a sequential treatment plan for taking care of this patient. Does this look familiar to you? Where did you see this first? Okay, I've been giving this lecture for more than 10 years in pre-clin, and this year is the first year Miss Lennon said, oh, I'm going to do it. Because I've been doing it from when Miss Heidi taught it. So that's why you're seeing this repeat. But the lecture she gave you was my lecture. So I'm repeating it, doing it how I would normally do that. So ADPIDE, really quickly, you will need to know this for boards. You will see it on your national board exam. You need to know what ADPIDE stands for, each letter, each section. So what we do here is we're going to, assess. We're going to get our data, then we're going to diagnose and assess that data and figure out, okay, this patient has AAP case type, whatever. We need to plan SRP, then we need to re-eval, then we need to refer to perio or whatever we're going to do. Then we're going to implement that plan, and then we have a re-eval here at the evaluation, and then we're going to document it. So that's the whole thing on the dental hygiene process of care. I'm quickly going to run through this. The assessment, the diagnosis, the problem ID. The plan is, what are we going to do for this patient? Then we're going to do the plan and evaluate it and document it. So I'm just going to run through this. What the patient says, what you say, what you see, what is the best thing for the patient. And you're going to use all kinds of things. You're going to do what you see visually. You're going to see what you see radiographically. You're going to figure out, okay, where is this plaque hanging out? Where is it? Is it just on the lower anterior? Or why is there a big hunk of calculus right here on both sides of the maxillary? Why do you think there's a big hunk of calculus right here? Salivary duct. So I can look at that and go, okay, there's a reason why there's calculus there. And when does it happen? When is the bleeding? Is it spontaneous? I had a patient once that his chief complaint, he came into my office and he said, my gums bleed when I kiss my chick. I was like, are you serious? How disgusting that is. But that's what his complaint was, a teenage guy. And he complained that his gums bled when he kissed. Okay, so when does it happen? And why is it happening? Is it a plaque-induced problem? Is it bleeding because of plaque? So one of your classmates today saw a patient, and the patient had very little plaque, but the gum tissue was slightly puffy and slightly sensitive and slightly red. Very little, but little plaque. So my first thing is what? Is this plaque induced? No, there's something else that happened. And I looked at the teeth and they were pretty good. They were pretty clean. What else is happening? So I asked the patient, I said, by any chance, are you between day 21 and 28 in your menstrual cycle? And she looked up at me and she went, yeah. Okay, now what happens to you when you have that 21 to 28? You get puffy, you get red, you get swollen, and you bleed. Why wouldn't your gums do that? It's hormonal. So you have to figure out what is causing this. Your job is to be a detective, okay? We're going to figure out what the problem is and how to fix it. That's what treatment planning is. That's what it's all about. And you're going to use your data collection sheet to do it. But then we have to figure out how we're going to diagnose everything. We have all this stuff. How do we formulate it? We gathered all this information, but we don't know what it means. We're going to try to identify what the problem is. And that's where you have to use your critical thinking. Okay, remember a couple weeks ago I talked about Christian's patient, where the patient had upper and lower anteriors red, swollen, bleeding. Nowhere else. Why? He was using a CPAP machine all night long. And it was red and swollen and bleeding. And I said, what's this? So we questioned and we questioned and we questioned and we figured it out. Okay. It's classifying it, sorting it, analyzing it, and trying to figure out what is making this red, what is making it bleed. It might be a filling that was either poorly done. It might be the rotation of a tooth where the patient doesn't have access to clean, or two teeth are jutted up against each other. You have to figure out what's causing the problem. And then you have to verify it. There's different strategies. If you don't know where you're going with a plan, you'll never be able to implement it. So you got to figure out who this person needs to see. If they're having a problem with a denture, who should the person see? PROS, okay? You can have a PROS consult come in. You can have someone from PROS come in. Hey, my patient's complaining, or Dr. Jewel, my patient's complaining that her denture is loose. Do you ever ask your patient, how's that fitting? How many of you guys have done a denture comp and asked the patient, oh, how's that denture fitting? 1, 2, really? You should be asking, how's that fitting? Is it doing okay? Because then they can get it relined and get it fitting good again. Okay? Whether they need a comprehensive oral exam, whether it's time to take x-rays, whether you're going to do the treatment plan where you're going to implement new oral hygiene tools, whether you're going to do a prophy or a root planing or a perio maintenance or a re-eval. What are you going to do for your patient with the information that you collected? And then people go, well, how do I know what recall to put this person? Is everybody automatically 3 months? No, what helps you decide a recall?
How heavy the
So once this plaque score, what do you say?
How heavy the calculus?
How heavy the calculus is?
Pocket.
Carries risk.
Pocket.
Pocket depths, bleeding. Okay, so one of the things I look at is when was their last cleaning? And what do I see today? Okay, so if their last cleaning was 6 months ago and they're pretty clean and they're a perio maintenance, what's wrong with putting them on a perio maintenance for 6 months? Nothing. But if I don't have that upper section on your case presentation form that says when was the last cleaning, then I can't make that judgment on how much is there. Now let's say their last cleaning was 3 months ago or 4 months ago. Let's say it's 4 months ago and there's a ton of plaque, ton of stain. What kind of recall would you want to put them on? Back it up. Go back to 3 months. The reason why we ask you when was the last treatment, when was the last time they got their teeth cleaned, that's going to help you know when to do a recall. Because if there's a ton of plaque in there and it's, let's say, they came in 8 months ago for their perio maintenance, ton of plaque, inflamed, no change in cal, what's the problem? Why is the gum tissue bleeding and red? Because they got perio all over again with no cal? All it is they need to be flushed out. Here's how it works. So the patient comes in, the bacterial load is high. You come in, you flush it out with your ultrasonic, you scale it, you bring the bacteria to here. The body fights, and it does really good. And about 3 months later, the body goes, oh, I can't do this anymore. Bam, the load is there, the tissue gets red, inflamed, maybe bleeds a little bit. You come back in, you flush them out again, and you take them on their way. About 2 or 3 months, 4 months, the bacterial load's up here again. That's what, your body's an amazing thing and it can fight for a really long time, but once they're not able to clean out well enough, you need to get them back in here and flush things out again.
Leslie,
Yes.
on that slide, perio maintenance, perio re-eval, and recall. So perio maintenance is just coming back in because they had periodontal treatment before.
Okay, let me start from the top. A prophylactic prophylaxis. What does the word prophylaxis mean? Prevention. So if they've had disease, do we do a prophy again? No, we can't. We have nothing to prevent. Okay, so prophylaxis is somebody that doesn't have cal, they have not had bone loss associated with perio. Okay, root planing is now we have disease, we have to do active therapy or active treatment. What kind of active therapy is that? Scaling, root planing, ultrasonicking, all that other stuff. We're doing that. Okay, now the patient comes back, we have to tell the patient, now I need you to come back in to see if what I did any good. That's when they come in for their reevaluation. After they come back in for their reevaluation, now I need to evaluate. Are they okay? Are they out? Are they in remission again? Are they maintained? Or do we need to refer them to grad perio or refer them to a periodontist if we're in private practice? Right? So then, they're doing pretty good, we're gonna hold. So now, and I'm gonna have them back in 3 or 4 months or whatever it is and say, now we're gonna maintain your perio condition. It's holding, we're gonna maintain it right here. That's what your periodontal maintenance is, to maintain that condition where it's at. You might have had attachment loss, but it's holding. It's not gotten any worse. And then your recall. Does that make sense to you? Okay.
So once a perio maintenance, always a perio maintenance.
Generally, yes.
Okay.
Generally, that's how it works.
So it goes reeval, maintenance, and recall.
Okay, work your plan. Always doing oral hygiene before you do treatment. Why? Because I'm going to clean up your teeth, and this is a partnership between you and me. I could do the best job scaling and root planing here, and you go home and you don't do your job, I guarantee my treatment will fail. I always tell my patient, this is a partnership between you and me. I'm going to do the best job I can here, but you have got to do your job at home. And I put the ownership on them because I've done my job. We're going to work together to help you heal. Okay. Generally in private practice, we always do our scaling and root planing and clean them up before we get them to do their restorative work. Why? You build a house on a firm foundation. You make sure that perio foundation is good before you put a crown or whatever you're going to do on that tooth. You all know what we're doing in a re-eval is to figure out whether or not what we did any good.
So we're disclosing every appointment, disclosing an OHI every appointment?
You don't have to do that every appointment, but sometimes it's just helpful to get a good look in there. So even if you're not doing a oral hygiene instruction 2 or whatever, let's say I had a patient, I did data collection, I did OHI, and they were doing okay. I gave them a couple of tools, but I wasn't doing a comp. Can you disclose, again, without doing a plaque score and just kind of show them a couple of areas? Absolutely. Absolutely. If that patient needed it, do it. You don't have to, chart all the plaque, but you could just say, hey, I'm just checking to see. We're just going to quickly disclose and just slather it on. Put your Vaseline, slather it on, and then rinse them out, and then show them in the mirror. Hey, you're doing a lot better. You've been using that tool I gave you? Yeah, I love it. Great. Now it's just a double check to see whether it's good enough. And then it's good for them because they feel good because they've done a good job. Anyone know where this is? This bridge? It's up near Monterey?
Yeah.
Love it. I took this picture shooting at this bridge from here, and I just caught these flowers. It was really pretty. I like the Central Coast. All right, so here's your decision tree. I know when we first gave you this lecture, you're looking at this going, oh, there's so much stuff on this thing. But you all pretty much know how to figure out a category. Okay, that category is internal to Loma Linda. It's just to make sure that Sabine didn't just see only category 1 patients the whole time she was here. We're gonna look and see that she got some 1s and 2s, and she got a 3 and some 4s too. So she had a good variety. And figuring it out, this is all how you figure out. The perio diagnosis, or you're pretty familiar with the new stuff. Healthy, healthy with reduced periodontium. So give me an example of someone who might be healthy with reduced periodontium. Okay, it could be a perio maintenance that's pretty clean
No bleeding.
and no bleeding, no anything like that. Or it could be someone that has had orthodontic treatment, and you know how you get a little bit of bone loss sometimes when you move teeth too fast through the bone. If your orthodontist moved too fast, you may end up getting a little bit of interproximal bone loss, just a little bit. Okay, that's me. I'm healthy with reduced periodontium because I had ortho when I was an adult. Right? And these. And then this section, I'm just going to quickly go over that decision tree because it will help you see what we're going to do. So if you're doing a prophy with some little bit of inflammation, you collect your data and you go, is there attachment loss?
No.
No. Is there inflammation? There's a little bit localized. So what I'm going to do is a prophy. Does that make sense? Go through that? Now they come back in again 6 months later, and I'm going to go through this same process, going through this. And if it changes, then we're going to do something else other than a prophy. So now here's prophy with moderate to severe inflammation. They have attachment loss? No. Inflammation? Yes. It's generalized. Now we're going to scale in the presence of inflammation. Then we're going to do a re-eval and a prophy if controlled. And then we're back up here the next time we come back in. So let's say you collect data, there's attachment loss, and we say, yes, now we have attachment loss. It's not controlled, so we're going to do an SRP. We're going to do a re-evaluation. We're going to maybe see them 3 to 4 months and back up data collection. The next time we come back in, same thing. We're going to go through that decision tree. Now you guys can pretty much do that decision tree in your head. Yeah, you should start being able to do all of this in your head. Here is the scaling and root planing with a perio re-eval because it's uncontrolled. So we did all of this. We came down to the SRP. Here's your re-eval, 4 to 6 weeks. And any area that's not controlled, we're going to have the periodontist come by, and he'll either say there's surgery, and then after the surgery, we're going to have you back into the maintenance, and we'll run through that whole thing again. Is it making more sense than the first time it did? Okay, we learned a lot. Perio maintenance, same thing. Attachment loss, but it's controlled, so we're going to do maintenance 3 to 4 months. Category, we did all that. I'm going to run through this real quick because you all know that. ASA, you know. Gull Lake. Anyone been there? Where's Gull Lake?
Oregon.
That's like Northern
Mammoth. Up near Mammoth. Okay, your case presentation form. This is where you're going to take all the conditions that you found, organize them on that form, and tell your instructor what you found. You're going to do it by your histories, your radiographs, all of the stuff that you did on your data collection. This is what you're going to do. And you're going to put it right here on this form. So one of the things that was I see very few of you doing is filling out this section. Okay, if you have a cash patient, circle the cash. If you have an insurance patient, circle insurance. If you have a Denti-Cal patient, circle DC or Denti-Cal. That helps the faculty know how to help with some of the modifying treatment plans. For example, Denti-Cal can only get a cleaning once a year unless you get approved for scaling and root planing. So we need to know that because if we get them back here and submit it to Denti-Cal if they've been here 6 months ago, the patient's liable But if you didn't inform the patient, guess who's liable? You are. Yes, Cindy?
Can you go over where it says probing, BOP?
I will. I'm going one by one all the way down this form. So your histories, do you see why contraindications and complications? Now, on that medical section where it says medical history, I don't want you to write every single thing. Kidney problems, this problem, that problem, they have psoriasis, they have this. That's not what we want. It's anything that's going to contradict your treatment, or change your treatment, or modify your treatment, or you have to be aware during your treatment. Like patients on a blood thinner. I want to know that. Okay. Your last visit, we already talked about why that's important to know when they came in last. When the last bite wings are, because I want to know, should you take bite wings? Should you take x-rays on this patient at all? What do they need? And then when was the last time a dentist looked at them? Okay, and then any consultations we need. Sunshine.
On that sheet, I know it's not there, but it says last date of hygiene / perio visit, and then last hygiene perio procedure. So,
I'll go through that. I'm getting there.
oh, okay.
Okay, here it is. All right, so this is medical complications, contraindications to treatment. So don't list out every little thing, oh, they got a sore on their leg and then blah, 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 whatever. I want to know what is contradicting or what I need to be aware of in my treatment. Your last hygiene visit, let's say they had, the last hygiene visit was 6 months ago, but they had perio surgery 3 months ago. I want to know when they saw a periodontist or hygiene, anything to do with hygiene. Okay, whether it was in the main clinic by the dental student or whether it was a hygiene or whether it was perio. Okay, because maybe perio did the SRP and now we're seeing the maintenance. I want to know when that was. And then this section is, what was that procedure? Was it a perio maintenance? Was it a SRP? Was it a graft? Was it whatever? This is the date. This is what kind of procedure it was.
We put the date and then we would put like.
Okay, date of the last hygiene visit or perio visit, whichever was last. And what was the last procedure you did?
Okay.
Was it an SRP? Was it a re-eval? Was it maintenance? Was it a prophy? Because that helps me know they were a prophy last time, but now you're diagnosing SRP. I want to know what happened. Oh, does that make sense? Huh?
I just put down date.
No. I want to know what the procedure is here. I want to know what the date is here.
That makes sense.
Okay? And then the last dental exam, like when did they have a POE? And the last perio consult, because maybe that was important, depending on what your treatment was. And then the radiographs. So maybe here's your FMX. Maybe they had an FMX 3 years ago. Is it time for a new FMX? Maybe. Okay, here's another thing. 3 years ago, they had an FMX. 1 year ago, or 6 months ago, they had bite wings. No, because bite wings are part of an FMX. If the bite wings are still good, we're going to leave it alone. Unless you have a periodontal issue and you're doing SRP, then the periodontist is going to want new films. Yeah.
What if they lack posterior teeth, and we need like anterior x-rays? What do you cut in place? Because you can't put bite wings or FMX.
Radiographic need right there. PAs. 6
Should you
PAs.
just say 6? Okay.
6 PAs.
Oh, I'll text you.
Is this helping to review what this is supposed to be? Okay. All right. So now, radiographic evaluation. This is what you're going to do. You're going to look at the most current x-rays, and you're going to say, is there any bone loss? Yes or no? Is it generalized, localized, angular, or is there none? So it might say generalized, slight bone loss, localized moderate bone loss. because maybe one section has more bone loss than the other. And then this section here, I see a lot of people not knowing what goes in this section. Sandra?
Do you ever have generalized moderate, but there's only one area that's like localized, or would you just consider it all generalized?
Say it, generalized moderate.
And there's just one area that's localized slight.
You could, but if it's generalized, it's going to be generalized. Okay, so this section right here, it helps us to know what's happening in that patient's oral risk or their oral assessment. So if they have had past oral cancer, I want to know that right there. If the patient is at caries risk, I want to know that. If they have a broken filling or restorative, I want to know that. If they have xerostomia, decreased saliva, I want to know that here. Or any other observations. I could say patient's tongue-tied, patient has whatever else that might be associated with that condition. Put it right there. Yes?
This is a weird question. Is geographic tongue something that can go away?
We learned yes in past.
I would say it can, because sometimes it goes away and it's not exacerbated, and other times it can flare right back up again. So it might be not evident there at that time, but then it may be later on. Okay. Now, let's say you saw a pathologic lesion, or you need to have that done. You're going to tell whatever that might be that you found. Geographic tongue, whatever. And it's not like linea alba. It's something that you really need a consult for or something. I'll get to you, AJ. And then what kind of consults do you need? Maybe you need a path consult. Maybe you need an endo consult. Maybe you need an implant consult. Whatever consult you need, put it there. AJ?
Okay, with pathology and EOIO, if something is listed before, so let's say fibroma or something in a previous note, do we have to list that again? Or so for, let's say 6 months ago, irritation fibroma was noted, will we note again irritation fibroma?
On something that is no effect on anything, because a lot of people will have linea alba, they'll have a fibroma, they'll have amalgam tattoo. Stuff that's not relevant, that needs attention, that's not what I'm looking for. As long as you talk to your faculty, say the same fibroma is there and it's still the same 2 centimeters.
Got it.
Okay. All right, this is what it looks like to be marking something. So slight, generalized, moderate, localized, angular, if you want to do it that way. Right? So look at your radiographs. That's how you're going to mark that. Here's all the stuff. Okay, here's the reason why we want to know previous cancer risk. Or are they a cancer risk? If they're smoking and using tobacco, you just heard, increase the risk. So you're going to make a notation of it. The Canberra caries risk, if they have multiple restorations or they're high caries risk, and any broken or open margins or whatever you find. Sorry, I bumped ahead there. Okay, if I notice a crossbite, abrasion, erosion, abfraction, tongue thrust, tongue tie, that's where you're going to mark it right here. Is this helping you to be more thorough?
Yes.
Okay. Note any pathology there, and your head and neck page right there. And where the lesion is, draw it. Have any of you drawn lesions?
Yes.
So you all know where to draw it? Huh?
On that tab, I have none.
Okay, so when you go into this tab, if you click on the abnormality, then it has these sections here that you could get a full face view, like if they have something right here, Maddie, then you want the full face view so you could draw it there. Or if you just want the hard tissue, or if you just want the soft tissue, then you could draw it in there. There's a colored tab there. Click on it, and then you can draw right where the lesion is.
I also noticed in that tab, there's like a narrative section.
Just type out what you saw.
Okay.
3 millimeter firm, blah, 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 blah.
You could draw mandibulatory there, like you have
Yep.
to draw it?
You can draw it in there. It's part of a lesion that's in the mouth. Okay. The reason why we want you to draw these things in here is so that we are in the same area. We're describing. It's hard to just sometimes describe. Like I can be very specific about a fibroma located in the left commissure of the lip. We know that's right here. But sometimes where it's in the buccal mucosa, just opposite of tooth number, blah, blah, blah. If you draw it right in, it's easier to find. Use red. It shows up the best on that black and white. Someone that we had today used a different color, and used black on one face that had all these black dots on it. And I go, well, which one is yours? Okay, you just do it in red so we can see it. Okay, so here's what it might look like. Okay, you have a patient. This is what you, last procedure was a maintenance. Here's the date, the FMX, all this stuff. I guess I did put the fibroma on the lower lip. Okay, so now papilla, color, contour, and consistency. The marginal gingiva and attached gingiva. Why is it important to mark all those? Because I want to try to figure out why that is red. Why is it bleeding? Why is it inflamed? What's causing that? What can I do to fix it? Here's what it might look like when you're drawing it. Papilla is red in the upper and lower anterior. It's bulbous, but this one is cratered right here. This is rolled. Frenum problems right here and here. Okay? So let's talk about frenum problems. Gingival evaluation. What is this arrow pointing to?
The recession?
Gingival margin.
The gingival margin's right here. Mucogingival junction. Okay, this is your mucogingival junction. So if I follow it here, okay, right to there, I should be able to probe right here and stop right there, correct? Right. But if I look at this one and I follow that line right there, can you tell that I can probe and I'm going to go straight through that? Okay. That tells me there's no attached gingiva because I'm probing straight through the mucogingival junction into, what is this? That's the mucosa. Now I'm not in gum tissue, I'm in mucosa. No attached gingiva right here. Mucogingival junction, there's where I would probe. And now I'm going to probe past the mucogingival junction. How many of you have been looking for that? Okay, a couple of you. When you're looking at your gum tissue, that's what you need to look at. It doesn't look like there's good. See how much attachment there is here? A lot of good attachment. This has none. So
Why?
Why?
You're about to say.
You want to know why? What's this? Every time the patient talks, every time the patient eats, it's pulling, 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 pulling. So
It's interesting that it wouldn't be both then, you know?
The tissue happen to be thinner on this side.
Yeah.
I don't know. But you have to look why. Why do I have less than 1 millimeter of attachment right there? Because that's a problem. So what can they do about it? Sometimes if it's attached, sometimes I've seen it where this problem exists right here. They'll take this and clip it right there. Frenectomy. Okay, easy to do. It takes just a few seconds. Once it's numb, they just clip it, or they'll use a laser to just clip that right there.
Are you saying that the attachment loss is due to the frenum?
Likely. And it might be a combination because can you imagine that tissue is probably really sensitive? because it's really thin, so the patient's probably not brushing it good, so there's probably plaque buildup in that area. So it's a combination of plaque and frenum. Here's another one. Okay, so I've got my mucogingival junction right there. And if I probe, I know I'm going to stop about right there. Right here. But see, this is really thin tissue. I'm going to probe right through here. Can you tell? Have you seen patients like that? Have you been marking it? No. Will you mark it now? Okay, here's more on the data collection. I'm running down that sheet. Can you tell where I'm going with all of this? Okay. So, I'm looking at probing, bleeding, furcations, mobility, recession, attachment, and then calculus if you're going to do a calculus assessment. So, all you want to do here is compare or summarize. The probing, I'm going to say increase PPDs to 7 millimeters. I don't want you to list every pocket that's there. I just want you to give me an overview. It's comparatively to the last time they were here, the pockets are increased and they go to 7 millimeters.
So if they had a 7 millimeter last time, you don't have to write it again?
I would still, this is what I'm going to summarize to my faculty so they get an idea. Okay, now I know that the pockets are between 1 and 7. Thank you.
So if, let's say, would we just count the deepest pocket depth that we found, or would we be general? So if they were,
You could do general, or you could do increase to, and I just, in this one, I did it to 7 millimeters. It's kind of depending what the picture is. Okay. BOP, I could say moderate localized BOP, interproximal posteriors, because it's generalized that. And I can say it's increased from the last time, so draw an arrow up. Furcations, just give me a rundown. Don't tell me, oh, 3 has class 1, 14 has class 2. I don't want that. Just give me generalizations, class 1 to 2 furcations. And mobility, minimal mobility. Maybe you have a tiny little bit on the lower anterior. And then you have 4 to 6 millimeters of attachment loss in general. Just give me an idea of what's happening in that patient's mouth. And then this part on the notes section, anything else that doesn't fit anywhere else. For example, patient can't lie supine due to a neck injury, communication due to hearing loss, have to have a caregiver there, any place else that doesn't fit here but still affects your treatment. Anything on data collection? A number of you are starting to use your loops and are loving it. There's the other section of you that are still struggling because you don't have your loops yet, but it's coming. So we'll start working that. One of the things that I've shown a number of people this last 2 weeks is on probing. I didn't put a slide in there, but if you look at your probe, I'll draw it big. Okay, I exaggerated this a bit, and it's not to scale, but if you look at your probe, you see a line here, that's 1 millimeter, a line here, it's 2 millimeters, a line here, it's 3 millimeters. The bottom of this thicker black line is 4, the top of that thicker black line is 5. Okay, so I had a student today who was doing 4s and above. But in her data collection, she charted every single tooth, all of the data, full data on a patient, when all she needed to do was 4s and above. So how do I do that quickly? I think on my probe, the bottom of that black line, and I'm just going like this until I don't go, oh, that's a 2, that's a 3. I don't even pay attention to that. I'm just looking for anything that's 4 or above. Don't put those numbers in your head. Just look at the bottom of that black line and keep moving your probe through until you get close to that. And if you need to stop and go like this, okay, you can. and then keep going, because that's a 2, that's a 3. But you don't have to memorize the numbers. You don't need to know. It's below 3, you don't need to know. Does that make sense? Okay. Don't worry about those numbers. You can run through faster. Sunshine.
So data collection is 1 year, right, up to 1 year, but for full data collection.
Any patient you have, whether it's prophy, whether it's SRP, root planing, whether it's perineal maintenance, full data needs to be done once a year.
The health history is 2 years.
The health history to change control R, everything's 2 years. So I'm going to ask you to do this. I've asked a number of you to do this. Go back to spring quarter junior clinic. In my announcements, I have a whole thing of when to update a medical history and when to do 4s and above and what you have to do. Go print it up and put it in your binder. Spring quarter announcements. It's early in the announcements from the very beginning. It tells you when to do 4s and above, what's included, what you have to mark, and then the health history, when to update, when to get a signature, blah, blah, blah. Copy it, put it in your binder until you memorize that. Yes.
For perio maintenance, like let's say the first appointment, you did the planning, so like it's already planned and consented for. Then they come in like the next week, you don't have to probe.
Did you have a treatment plan already?
Yes.
No need to probe. Let's do health history, vitals, EOIO, instructor
Plaque score,
check,
that's
plaque
what
score.
you do.
Okay? Yes.
I have a question on this. If your patient doesn't change, because we're just comparing, usually I put none. Like if there's no
Just put same. Okay? Because there's never a none, just the same. Okay. Okay, deposits. We want to know where it is, whether it's localized or generalized, and what's causing it. Are they missing? Now, if you've thought about it, patients generally brush better on the side opposite of the hand that they're using. So if they're right-handed, they tend to brush better on the left side for some reason. Just know that, because you're going to find more buildup on the right side if they're left-handed. Same for the left-handed person. It might look like that.
Excuse me, I have a question.
Yeah.
How we should figure out about this subcalculus before we didn't try this Explorer?
Well, you should have been exploring on your data just lightly. And when you get good enough, as you get better, you can start feeling calculus with your probe. Okay? You should be able to feel calculus with your probe. Oh, I feel that's rough. Something's there. It will come if you're not totally there, but sometimes you can feel big humps down there. Okay, your gingivitis diagnosis here. Tell me where it is. And this is your diagnosis stuff here.
One more question.
Yep.
So when we figured out the patient, she or he has perio, so they won't be the first one, gingivitis. So it's one of
Can
them.
you have gingivitis and periodontitis at the same time?
No,
Yes.
it's one of the two.
Okay, think, what is gingivitis?
No shower.
No cow, no fertigation, and bleeding, yes, inflammation.
Okay, wait, let's back up. What is gingivitis? What does gingiva mean?
Inflammation of the gingiva.
Okay, so what does itis mean?
Inflammation.
So inflammation of the gums. If you have perio,
Bone, fertigation, cow, all that is
you will have both generally, if it's active perio. Because they're going to be bleeding and they're going to be inflamed, right? Or inflammation of the gums. So usually you have both if you have perio issue going on. Yep.
I'm pretty sure my instructor, I had wrote both because I thought so too. But she was telling me that if they have bone loss, it's automatically perio and not
That's the reason I asked.
But you can have both. You can have gingivitis going on at the same time. What does gingivitis mean?
right.
And is every place that you have perio, you have You might not have period everywhere, but you have gingivitis here and period here. So I think you could have both.
I swear that was in a lecture.
Yeah, Dr. Parsi told us that periodontal disease is part of gingivitis and periodontitis, but that periodontitis and periodontal disease are not the same. But that if you have periodontitis, then you no longer have gingivitis.
They're both part of the disease.
I think it's part of the disease. That's
Yeah.
so that's what I'm looking at. That's what I'm looking at. I usually mark both. Okay. But I understand what he's saying because now you're no longer just gingivitis, you have perio.
Yeah.
But when you have perio, to me, if you have active perio, am I going to find inflammation of the gum tissue? Absolutely. So. All right, and we talked about all of this stuff before, what we're going to do. So here's the problem that I have when I watch you guys fill out this form. When I say the clinical procedure, it is, what are you going to do? Are you going to do a prophy? Are you going to do an SRP? Is it quad 1 to 3 or perio maintenance? And are you going to do a re-eval if you're doing quadrant root planing? And what kind of recall are you guessing you're going to be on? And then any adjunctive treatment. So people go, well, what's adjunctive treatment? That might be like Orachix or Arrestin or some other treatment you're going to do adjunct to what you're doing. Home medicaments. They might be chlorhexidine rinse. It might be MI-Pace. It might be a home fluoride. Okay, home medicaments are, what are you going to give the patient a medicament to do at home? It's not your oral hygiene. And then your counseling, education, that's like tobacco or nutrition counseling.
What about OHI?
Nope, because OHI is right there.
Okay.
Okay? You're going to need a series of OHI. You're going to need aids. What are you going to need? Oh, they're going to need an end tough brush. They're going to need a perio aid. They're going to need whatever. So here's some active adjunctive treatments. Remember those things we talked about? Antimicrobials or localized therapies, Parostat. We're going to give them whatever.
We're going to in office. That's what we're doing.
No, it may not be. I mean, we could.
So like, you said it might pay to be a medicament.
Yeah, but that's a home thing. Like,
Yeah.
like I might irrigate a pocket with Paradex.
If we ultrasonic scale, should we always just add chlorhexidine then?
No, not necessarily. I mean, you want to pre-rinse with chlorhexidine or Listerine, but you don't have to. Like if I have a patient with ANUG or NUG,
Yeah.
I might put them on Paradex rinse to get them healed up. Home medicaments might be Biotine or any xylitol gum. Let's say they have dry mouth and they love gum to stimulate saliva. Make sure you're choosing something that has xylitol. Or maybe you want to just provide, you want them to rinse with some warm salt water. I like to tell my patients to rinse with warm salt water if they've had SRP. So that's what we want to do. You don't have to spell out periodontal maintenance. Just put PM. Shorten your stuff, okay? You're going to do a recall 3 months. Maybe you're going to do Orachix as needed. You're going to give them MI-Pace. You're going to do nutrition counseling and tobacco cessation. And you want to get them some interproximal brushes for home. You think it's going to take 2 appointments? You're going to begin with OHI on the first one, and then you're going to begin scaling at your next appointment. Or however it is. I want you to start to try to figure out how much can I accomplish. Because now I'm doing my case presentation, and it's 10:30. What do you think I could do? I could do OHI and maybe scale a arch or a quadrant. Just get yourself figuring out how much time I have and what do you think I can accomplish and shoot for it. You don't know if you're going to hit your goal if you don't set one. Okay.
Oh, I just want to ask real quick, what would indicate if a patient needs nutrition counseling?
Okay, good question. You haven't had nutrition yet, and you'll have that with Ms. Z. She'll teach that next quarter, I believe. So somebody that maybe they have a lot of respirations, they're caries prone, maybe they're a snacker all day long, or maybe they're just eating or drinking soda pops or whatever, and you try to get them to have a more rounded, balanced diet. Or maybe you have somebody that has like angular cheilitis and they're not eating enough vitamin C or something like that. You gotta see what is, evaluate their diet. Maybe they're diabetic and their blood sugar is out of control, or it's too high and you wanna see if you can drop it. Let's see what they're eating. Because you'll do like a 3-day diary, or I think you might do a 3-day diary. We used to do that. I don't know what she's going to do this year, where you get someone to write down all the things they've eaten, whatever, for 3 days, and you kind of evaluate it. Mm-hmm. Okay, and then you got to put all the stuff in Perio page 5, right? Everything from that case presentation sheet goes in Perio page 5. Okay, let me back up here. Do you want a break, or do you want to just do this last little bit? Okay, last little bit. I only have like 3 or 4 more slides. So here is a case presentation that I had a student write. Okay, I want you to find problem areas that you see that don't match with what one section of this doesn't match with another section. So the patient is pregnant in the 2nd trimester. They had their last hygiene visit was here, and it was a prophy. The FMX is here. So I'm saying they need an FMX.
They're pregnant.
Okay, so can you treat a patient in the 2nd trimester? Yes. Okay, so that's cool. This is where I have my first problem. How do I know I need an FMX? How many years has it been? 3. So do I need an FMX? No. How do you know that? Okay, if I had a perio patient and I'm going to do SRP, I'm probably going to want an FMX, right? Because we want to see any current bone changes that are going on there. But this is a patient that just had a prophy. That FMX was in 16, so what do I need instead? Light wings. Okay. I look right here, and the patient has generalized slight bone loss. Patient has sensitivity in the upper and lower anteriors, and I see a bunch of erosion. Where is that coming from?
Pregnancy?
She's pregnant. So what's happening? She has morning sickness. Okay, so this is, see how I'm thinking? Okay, this goes with that. This goes with it. It all has to match. Okay, pyogenic granuloma.
Pregnancy.
Okay, it's all matching. Okay, so...
Doesn't she need a path consult anyways?
I left that blank because I want you to tell me, do we need a path consult?
Yeah.
Yeah.
Yes.
Okay, so now I have upper and lower anterior red. It's bulbous. It's buggy. I forgot to mark buggy, but it's right there. Okay, but the marginal region is a little bit red. It's upper anterior. Here is what's happening. Scroll. Okay, so what's happening here? It's all associated with pregnancy. Inflammation. What happens when you get pregnant to your hormones? Hormones going crazy. Okay, a lot of times you will see pregnant women with inflamed gums, bleeding, but no bone loss. Okay, so you have to tell your pregnant patient you must be meticulous with your oral hygiene, especially when you're pregnant. We'll really emphasize that. Okay, now I got something right here. I've got it clefting, and it should have been right there. I made the dot here. It should go right here. And by the way, no, I have your thing on my desk. I left it on my desk. Right here, it's got some clefting right here because there's less than 1 millimeter attachment. That's right here, 6 and 11. Okay, what's right here at 6 and 11?
Canines?
Okay, right above it.
Frenum.
Frenum. So they have clefting, frenum, because the attached gingiva, there's less than 1 millimeter of attachment up there. So these all match here. Okay, light plaque, just light localized supra and lower anterior. There's no sub and no stain. So we got slight inflammation here. So here's what the patient, what the student said.
Bless you.
The probing has increased, bless you. Probing is increased to about 4+ millimeters. And there's bleeding. There's no furcation, mobility. We got some recession going on at 6 and 11. But they said no attachment loss. Is that true?
Absolutely not.
Why? Do they have attachment loss? Yes, because what's happening? We lost something there with this. So this should say yes, attachment loss. And patient is anxious, so I'm going to use nitrous.
No.
No, that's wrong. Okay, it has, if you said that, then I'm going to go, that doesn't match. Okay, now, they want to do an SRP. Tell me why you think they don't need an SRP. Okay, so Adrian says the patient's pregnant and she probably has gingivitis, inflammation. So when you get inflammation,
Your depths are gonna be
your depths are going to be deeper. If you go and you don't brush your teeth for 4 days and you come in and probe, okay? If I come in and you come in and I probe you, will I find 4 millimeters? Maybe. Okay, will you be red and inflamed?
Yeah.
Maybe. Do you have perio? No. Probably not. So I want to know, where's that 4 millimeter pockets coming from?
That's for the inflammation.
Inflammation, because she's hormones, because she's pregnant.
So
Yes.
is that what the negatives are when you're doing recession?
Yes.
Is the gingiva is up?
Yes.
Okay.
Okay, so she wanted to do an SRP with 4 to 6 millimeter, 4 to 6 weeks re-eval. She wants to do a Restin MI paste because this patient is sensitive. Why do you want MI paste?
Remineralization.
Remineralization, because she's throwing up and ruining her enamel. Okay, and she thinks she wants to get an extra soft toothbrush, a Nimbus, for that area right along here where the frenum is and the tissue's really thin. If you have an extra soft brush, that'll work really well for a patient that has really thin tissue. All right, so here's all my corrections. Okay, the pregnancy thing doesn't match, the hormones changing, we're not going to use nitrous, we're not going to do this stuff, we're not going to do an SRP. Okay, frenum problems here, they didn't mark this as a frenum problem, but it is. So when I'm looking at that sheet, I'm cross-referencing all across that sheet. So everything, if you tell me there's no bone loss, and there's clinical attachment loss, I know something's wrong. They don't match. That's how critical this case presentation form is to help you organize your thoughts. Now, when you go to private practice, you won't have this, but you're going to look at your data, you're going to go bam, 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 and you will just know this, because by the time you're done here, you will have this memorized, and you can fill that form out in less than 2 minutes. How long is it taking you to fill out that form now?
30 minutes.
I agree.
Right? Do you think it's going to be easier
I
to fill out
finished by
this form now
10:30.
that we talked about some of these things? Can you just go and tick things off really quickly?
No way. Oh, well.
The next appointment.
I have other instructions by 2 different instructors, 2 different ways. So I think the instructors should also be updated about this. Because
Give me what they are. Maybe they're correct. Maybe it's just, I'm just giving you,
For the probing, it was either, it was like the pockets amount, but it was all either increase or decrease. And if it was like BOP just none, or the other one said compare it to the last time.
Well, that's what it is, comparing here. So it's increased from last time. It's increased from last time. There weren't any. So we're doing the same thing. We're just writing it a little differently, but we're saying the same stuff. Because most of those faculty up there, I gave this lecture to when they were students. That's Miss Z. That's Miss Ellington. That's Miss Smith. That's Miss Chatney. That's Miss all of them were students that had this lecture for me. Yeah, I'm that old.
So, what exactly on this form was updated from like the previous quarter? Because I remember we didn't get this for a long time because Miss Lennon was working on it.
So what was changed was this section right here. This stage 1, grade 1 perio stuff, that has changed. The rest of it, she added, I think she may have added the word camera. I put carries before. I think she added camera and that's about it. All right. Are there any questions? Yes.
I had a question about the sealants block.
Okay.
So
Listen up, sealant block.
So we've been told that I got your announcement. We need to have our X-rays evaluated by Dr. Jewell and everything by the beginning of next week.
Yep.
So I was wondering how that block is going to go. Are we supposed to be with a partner and get evaluated with that partner?
Okay. You are doing sealants this coming week in, not this week, but next week in dental materials. You will do it on a typodont, on some teeth in there.
This week, I think.
Is it this week?
Yeah.
No,
Yeah, we do
It's this
sealants
week.
this week.
Okay, I'm sorry. I keep thinking it's your OSCEs this week, but you're doing sealants this week.
Yeah.
They will give you more instruction. So who normally runs that sealant block is Mrs. Armstrong, and she's out. So I saw Miss Marshall come up and talk to Miss Z and said, "You're running it," because she's not here. So Miss Z is going to be running it. So you will have a partner. You and your partner need to be in each other's family. You will do the sealants on them. They'll do the sealants on you. And then you will have an assistant, I believe, to help you. So there's 3 of you in a little pod.
So my thing is, we were just like, I think the majority of us, when we were on clinic, if they're just random people that don't have a patient, we were just told pair up and get in each other's family, blah, blah, blah.
That's going to be your partner.
Only half of the class is doing sealants at a time on the block schedule. And so, like, for instance, the partner that has me in their family is not signed up for the same day. And I think that's, like, the case for a lot of people because that date wasn't taken into consideration.
So I think it should be to do our screening and then when we get there, just have
Yeah, you can just partner up and put the treatment plan in later on.
So it's okay that it's, like, in one person's name and then done by
You'll have to just redo that again, but it'll take a short time. I normally don't run that block, so I didn't know what was going on over there. Danny?
I have sealants on the 19th of August.
Okay.
So can I push back getting my sealant check to like next week? Because I haven't had mine checked yet because I haven't had the time.
I suppose it would be okay. It will be okay, but just get it done because Dr. Joel's trying to get everybody sealed so they can get in the families and hold it. Okay, it's not critical, but.
What is the difference on our clinic schedule of sealants and then sealant assist?
You're going to be the assistant, assisting 2 people doing sealants on each other. So there's 3 people because sealants, the number 1 failure for a sealant is contamination by saliva. So you've got to keep it dry. So that assistant is critical to working with your sealant. I actually had a patient once. This is my private practice. Her mom works up here at the medical center. At the School of Medicine, and I was doing a sealant on her. I don't even know if I had an assistant. I had a cotton roll trying to keep it all dry in there, and all of a sudden she went like this. Oh. She swallowed that whole cotton roll, and I was like, oh! I was trying to reach it, and I missed it, and I was like, okay, that's coming out the other end. So having an assistant for sealants is really critical if you could get the help. Also, I don't know, for the last 8 years or so, I've been running the block out at Baldy View, and you'll get to do sealants out there with me. I may not do that this year. I don't know. There's been talk of letting another faculty do that, but Baldy View doesn't want that to happen because I've been out there for so long and I just know the roads out there. So I don't know if I'll be out there, but you will do sealants out at that block. Okay. Moral Bay. So, any other questions? I hope you'll be better about filling out your case presentation form, and then you'll understand why you're doing what you're doing.